Good morning, everyone at Aero City, New Delhi. I'm honored to be able to share my experience with all of you. We share a common and humble goal, and that is to improve care given to women and men with bladder pain. We agree that chronic pain conditions are often poorly understood. When I reviewed the available literature to better understand how to manage my patients, I found that there was a big difference in how urologists and gynecologists approach pain compared to pain specialists and physicians. There is an incredible amount of knowledge and facts, but how do we, as clinicians and urologists, gain insights from all the published evidence? I hope that this presentation will shed some light. Pain is an unpleasant sensory experience, and it has two components. One is a sensory experience where the patient describes a sharp or throbbing sensation. And two, an emotional reaction to the pain when the patient says to you, "It is so excruciating that I can't bear it." While acute pain is a result of injury and tissue damage, chronic pain occurs without actual tissue damage, and we need to accept the patient's awareness of pain even when there is no underlying cause. Chronic pelvic pain shares similar pathophysiology with other chronic pain conditions. In this recent article from Lancet Rheumatology, chronic pelvic pain, along with other conditions such as fibromyalgia, chronic fatigue syndrome, and temporomandibular joint disorders, have high central sensitization. To understand this further, we can approach bladder pain in the context of local injury and response, peripheral sensitization, and central sensitization. What does this mean? First, there is an initial insult or injury causing tissue damage and activation of local response. For example, the patient may have presented with a bladder infection or sexually transmitted infection. However, with peripheral and central sensitization, the pain persists even when local injury has resolved. If bladder pain is provoked by stimulus that usually does not cause pain, for example, patients may complain of severe dysuria when urine flows through the urethra, though the urine is clear, urine culture is clean, and cystoscopy is normal. Sensitization is likely, and in such patients, bladder-centric treatment has lower chance of success. In my opinion, this sequence of local injury and response, peripheral and central sensitization, helps us understand the difference between patients with normal and abnormal bladder appearance. So next, let's explore how local tissue injury and response occurs. The bladder urothelium consists of transitional epithelium covered by a superficial glycosaminoglycan or GAG layer. This is a tight barrier that does not allow any diffusion across. However, damage to this barrier from recurrent infection, chronic inflammation, or autoimmune conditions can result in changes in the urothelial barrier that permits toxic substances in the urine to diffuse into the underlying tissue. This leads to the activation of mast cells. Mast cells are rich in inflammatory mediators such as cytokines, chemokines, histamine, and substance P. The release of these substances generates action potential in the pain fibers. At a molecular level, there are changes in cell signaling. Upregulation of nociceptors or pain receptors lowers the pain sensitivity threshold, so even a mild stimulus may be able to generate intense pain. In this slide, pay attention to the nerve ganglia highlighted in purple. We're well aware that the bladder has rich innervation from sympathetic and parasympathetic and motor nerve fibers responsible for bladder filling and emptying. But remember, there is a fourth component of sensory fibers. These sensory axons in the bladder originate from neuronal cell bodies in lumbar or sacral dorsal root ganglia. The bladder neck and proximal urethra contain the largest density of bladder nerves. The muscle wall and lamina propria near the urothelium have the highest density of sensory innervation. On the other hand, the bladder dome and trigone have different innervation. The trigone and the bladder base have small diameter unmyelinated C fibers which are upregulated in interstitial cystitis and bladder pain syndrome. These fibers respond to noxious stimuli. Neurogenic inflammation occurs when the inflammatory mediators such as substance P stimulates growth of new pain fibers. Stimulation of these fibers causes neuropathic type of pain, which is burning or shooting in nature. The afferent sensory innervation for the rest of the bladder is large diameter and myelinated A delta fibers that respond to stretch and bladder fullness. Now, bladder pain is often poorly localized, dull, referred, or radiated. Paired pelvic ganglia innervate the lower urinary tract, the lower intestine, and the reproductive organs. This innervation has common embryological origin. The neural crest progenitors that migrate from the dorsal aspect of the neural tube towards the urogenital sinus. In addition, the afferent sensory fibers innervating the pelvic floor also arise from S2 to S4. This is why patients with pelvic floor dysfunction may have symptoms mimicking bladder pain syndrome. When there is tissue injury, inflammatory cells such as mast cells, macrophages, and neutrophils converge at the site of injury and release inflammatory mediators such as hydrogen ions, ATP, histamine, serotonin, and substance P, which directly stimulate the pain receptors and generate an action potential in the pain fiber. Other substances such as bradykinin, histamine, prostaglandin, and nerve growth factor lower the threshold needed to generate an action potential and send the signal. In addition, the neuron itself releases neurogenic inflammatory chemicals, substance P, calcitonin, gene-related protein, cytokine, and chemokine. My take-home message from this slide is the importance of correct initial management of patients with interstitial cystitis and bladder pain syndrome, who often present with a simple urinary tract infection. When there is a pain stimulus, the action potential is transmitted along the first order neuron. The second order neuron crosses the midline and ascends to the spinal cord, has the spinothalamic and spinoreticular tract. The spinothalamic tract mediates pain perception, and the spinoreticular tract mediates the emotional aspect of pain. There is also a descending pathway that is involved in pain modulation. On the other hand, central sensitization occurs at the level of spinal cord and brain. The first order neurons release substance P, calcitonin-related protein, cytokine, and chemokine. Glial cells release more cytokines. There is an increased excitatory transmission and loss of inhibition, and this continues with no stimulus. Because the threshold to generate an action potential is reduced, even a normal stimulus such as passage of urine can cause severe pain. In patients with central sensitization, treatment should target central mechanisms. Chronic pain arises when acute pain has not been managed, and the pain amplifies itself in a way that the stimulus is gone, but the pain remains. Peripheral sensitization occurs at the site of damage, while central sensitization occurs at the spinal cord and brain level. So the question is, how do we utilize all this information to manage our patients effectively? As urologists, we do have an important role in minimizing the effect of local tissue injury and response. And this is commonly caused by simple infections such as a urinary tract infection or a sexually transmitted infection. How do I do it? I manage UTIs with urine culture and antibiotic treatment. In patients with recurrent UTI, I ensure that the risk factors for recurrent infections are proactively addressed. If patients develop recurrent symptoms in spite of this, I perform a cystoscopy and biopsy of suspicious areas. This helps me differentiate patients who have other conditions such as follicular cystitis or genitourinary tuberculosis and non-specific bladder inflammation. When I see mast cells in the histopathology report, I know that this group of patients are at risk of chronic bladder pain, and I initiate treatment with pentosan polysulfate. Understanding that such patients develop symptoms of pain when the bladder is distended by urine. Other treatment options are anticholinergic medications and Botox injections to reduce bladder sensation and ensure that bladder capacity does not diminish. It is important to carefully listen to the patient to identify the change in the nature of symptoms. Occasionally, patients will complain of intense vaginal and perineal pain associated with poor urine stream, suggesting that they may have pelvic floor dysfunction and spasm. On the other hand, when patients with chronic bladder pain walk into my clinic, having had these symptoms for many years and undergone many types of treatment from various doctors, I'm beginning to realize that they very likely have pain due to peripheral and central sensitization. The bladder among this group of patients often appears normal on cystoscopy. This group of patients are difficult to manage and require patience and perseverance. There is some evidence that increasing magnesium in diet, improving sleep quality, and exercise may improve the patient's symptoms in the long term. I often get my psychologist involved to initiate mind-body therapy and movement therapy. I'm sure that most of you would agree with me that there is still more to be done in this area. With that, I thank Gibbs for this opportunity. Congratulations on the smooth organization of this conference. Your secretariat was most helpful. Signing off from Malaysia.